Welcome to the deep dive. Today we're plunging into a topic that's definitely been making waves in our ORs and pre-op clinics.
Mm.
We're talking about managing patients on GLP-1 receptor agonists, things like semaglutide, Wegovy, and really critical considerations for MPO status. And of course, aspiration risk.
Yeah.
It's quite the dilemma, isn't it? How do we keep patients safe when these meds are becoming so common?
It really is a fascinating challenge. We've seen this, well, almost explosive increase in GLP-1 RA use,
Right.
not just for diabetes anymore, but hugely for weight management.
Right.
And that's brought these new challenges right to our doorstep as anesthesiologists. And it's moving fast. The guidance has been evolving quite a bit.
Okay, let's unpack that. What is it specifically about these GLP-1 agonists that messes with our usual NPO game plan? The whole nothing by mouth thing. What's the mechanism?
Well, the core issue, the physiological effect, is that they significantly delay gastric emptying. These drugs, semaglutide, liraglutide, dulaglutide, Ozempic, Wegovy, Mounjaro, all those, they basically just slow the stomach right down.
Uh-huh.
And this isn't just a theory. It's, some shown pretty clearly in studies using endoscopy, ultrasound, scintigraphy.
So food just hangs around longer.
Exactly. It sits there.
And why is that such a huge deal for us during anesthesia? I mean, delayed emptying happens with other conditions too, right? Like bad diabetes.
That's a fair point. Delayed gastric emptying isn't totally new. But with these GLP-1s, it seems to be the degree of delay plus the sheer number of patients now taking them. That's really amplified the worry.
Right, the prevalence.
Yeah. And it's a big deal because that delay links directly to our biggest fear, pulmonary aspiration of stomach contents. During general anesthesia or deep sedation, that's just something we absolutely have to avoid. It's dangerous, potentially fatal, and our NPO rules are designed to prevent it.
And we start seeing cases.
We did. Anecdotal reports, case studies, things that made you pause.
Yeah.
Like there was the patient on semaglutide for weight loss, followed NPO rules, even stopped the drug a week before,
Yeah.
and still vomited undigested food when they were extubated after an orthosurgery.
Wow. Okay.
Or another one, a 42-year-old on weekly semaglutide, fasted for 18 hours, and scope showed a ton of food still in the stomach. Needed suctioning, even bronchoscopy.
So real-world consequences highlighting the risk. When these first popped up, how did the professional societies react? What was the initial advice?
Well, the ASA, the American Society of Anesthesiologists, put out consensus guidance back in 2023.
Okay.
And their first take was pretty cautious, quite straightforward, really. Stop daily GLP-1s on the day of the procedure.
Day of, okay.
And for the weekly ones, stop them a week before.
A whole week.
A whole week. And this was, importantly, regardless of why they were taking it, diabetes, weight loss, or the type of surgery, kind of a blanket rule.
And on the day itself?
On the day, if the patient had GI symptoms, bad nausea, vomiting, bloating, pain, they said consider delaying the elective case.
Makes sense.
If no symptoms and they had held the medication like advised, proceed as usual.
Okay.
But if no symptoms, but they hadn't held the med, that's where it got tricky. Treat as full stomach, basically. Or maybe do a gastric ultrasound if you could. If the ultrasound showed food or was unclear or you couldn't do one, then you either delayed or treated as full stomach.
Got it. Full stomach precautions.
Right. But the ASA was upfront that this was based on, well, pretty sparse evidence, just a few case reports, really. And they specifically said there wasn't evidence for needing even longer fasting times.
Okay, so that's where it starts getting really interesting, right? Because that guidance, while seemingly logical, it caused quite a stir. What were the problems people ran into, the unintended consequences?
Well, yeah, the biggest pushback centered on that dearth of high-quality evidence. Was holding everyone's meds for a week really necessary based on a few cases? And there was conflicting data emerging, like a big retrospective study, over 85,000 patients. That, kind of surprisingly, found GLP-1 use was not linked to more residual stomach contents.
Oh, interesting. So directly contradicting the smaller studies.
Exactly.
Yeah.
And then there was the whole debate about tachyphylaxis. Does the effect wear off over time? Maybe not perioperatively. Recent studies kind of question that. But it really forced the question, what are the harms of just stopping these drugs?
Right. It's not a risk-free decision either.
Not at all. Especially for our diabetic patients. You stop their GLP-1, you risk perioperative hyperglycemia.
Which leads to?
A whole cascade of potential issues. Longer hospital stays, surgical site infections, AKI, cardiac problems, ICU admissions, more time on the ventilator. It's not trivial.
Definitely not.
And then there's the logistical headaches, increased costs, fewer available beds because of cancellations, last-minute procedure changes.
Yeah.
Imagine being a bariatric patient finally ready for surgery and getting canceled.
Yeah, frustrating for everyone.
Plus, access issues. Bridging therapy isn't always easy or cheap. Patients might lose discounts. And, the point about potential weight bias was raised too. We manage gastroparesis without routinely canceling, so why automatically hold GLP-1s just for obesity? Also, think about the half-life. For semaglutide, it's a week. So stopping for just 1 week, is that even enough to clear the effect? Some studies suggested maybe not. Finding increased gastric volume even 3 weeks after stopping?
Yeah.
It's complicated.
So the community realized, okay, holding the meds might just be trading one set of risks for another. We're
Yeah.
kind of stuck between a rock and a potentially full stomach.
Precisely. That's a good way to put it. And that realization led to this more recent multidisciplinary consensus, a big collaboration.
Who was involved in
A
that?
whole group of societies.
Yeah.
ASMBS, AGA, ASGE, the ASA again, ISB COPY, SAGES. Basically, surgery, GI, anesthesia, obesity care specialists all came together.
Trying to find a more balanced approach.
Exactly. More nuanced, more patient-centered.
Okay, so this is the key part for us practicing day to day. What does this new unified guidance actually tell us to do? Pre-op, day of. How do we apply it safely and practically?
Right. This new guidance really shifts things. Let me break down the main points.
Please do.
First, and this is huge, shared decision-making is absolutely paramount.
Okay, talk to the patient, the prescriber,
Yeah.
everyone involved. Discuss the risks, the benefits, get on the same page. That's step one.
Got it.
Second, and this is the big paradigm shift, risk stratification, not blanket rules anymore.
So individualizing it.
Precisely. If a patient has no elevated risk, meaning no GI symptoms like nausea, vomiting, they're not currently increasing their dose, not on super high doses, no other conditions slowing their stomach, then the recommendation is continue their GLP-1 RA therapy perioperatively.
Wow, okay. Continue it. That's a major change from stop it a week before.
Huge change. Now, if there are elevated risk factors,
Such as recent dose increases, high doses, weekly dosing is considered higher risk than daily, any active GI symptoms, nausea, vomiting, pain, dyspepsia, constipation, or other conditions like known gastroparesis, Parkinson's.
Okay, so if those flags are present,
Then you move to step 3, diet modification. Recommend a liquid-only diet for at least 24 hours before the procedure.
on top of the usual NPO times.
Yes, in addition to standard fasting. Think like colonoscopy prep, or what we often do for bariatric patients. Give the gut a head start.
Okay, liquid diet for higher risk. Then what?
Fourth is day of reassessment and mitigation.
Right.
On the day, check again, no GI symptoms, proceed as planned.
Right.
But if there's still clinical concern about retained stomach contents, even after the liquid diet maybe,
Yeah.
then you have options. Consider point-of-care gastric ultrasound. If you have it and you're good at it, assess the actual stomach contents.
Recognizing limitations, of course.
Of course, user variability, availability. Or consider rapid sequence induction RSI for intubation. Secure that airway quickly.
Assuming general anesthesia, yeah. RSI has its own risks, though.
It does. Difficult airway situations, maybe not feasible for deep sedation cases where you weren't planning to intubate anyway. And crucially, the guidance emphasizes, try to minimize canceling the procedure, if at all possible.
Okay, cancellation as a last resort.
Exactly. Which brings us to the 5th point. Withholding the medication is the last resort.
Only if really necessary.
Only if, after that shared decision-making discussion, the safety profile is deemed unacceptable. Then you'd fall back on the original ASA 2023 advice. Hold daily doses day of, weekly doses a week prior, and still reassess for GI symptoms on the day.
Got it.
The consensus really stresses that stopping meds or delaying surgery has real consequences we want to avoid.
Are there other ways to mitigate aspiration risk besides RSI?
Oh, sure. Things like prokinetics erythromycin, maybe choosing an endotracheal tube over an LMA, keeping the head up during induction, maybe using an OG or NG tube before induction and again before extubation. Lots of tools in the toolbox.
Right, emergencies.
Emergencies are emergencies. Treat everyone as a full stomach, GLP-1 or not. That hasn't changed.
Okay, that makes sense. Now, before we finish, you mentioned other diabetes drugs, SGLT2 inhibitors. Quick reminder on those, because the issue there is different, isn't it?
It is, yeah. Very important distinction. With SGLT2 inhibitors like Jardiance, Farxiga, Invokana, the big worry isn't really gastric emptying, it's euglycemic DKA.
Right, diabetic ketoacidosis, but with normal blood sugar. Tricky to spot.
Very. And prolonged fasting makes it worse. So the guideline there is different and quite clear. Omit SGLT2 inhibitors the day before and the day of the procedure.
Day before and day of, unlike the GLP-1s where we try to continue if possible.
Exactly. Contrast that clearly. And for SGLT2s, avoid long starvation periods. Make sure they get IV fluids with glucose if the NPO is extended. Oh, and if you're on one of those very low-energy pre-bariatric diets, stop the SGLT2 when the diet starts, because the diet itself can be ketogenic.
Good points. Okay, wow. We have covered a lot of ground here, from the basic science, the initial sort of caution, the pushback, to this newer, more nuanced approach.
Yeah, it feels like we're moving towards a more sustainable strategy.
It seems the core message now is really about trying to continue these GLP-1s safely whenever possible, right?
Absolutely, that's the goal. Continue peri-procedurally in a safe way, holding meds, delaying cases, that's the backup plan, the last resort, and the single most important factor for deciding risk.
GI symptoms.
Presence of GI symptoms. That's your main flag. If they feel fine, haven't had recent dose hikes, etc., they're likely lower risk.
So for you listening, the key takeaway really seems to be, yes, GLP-1s add a layer of complexity, but we can manage these patients safely. It takes thoughtful assessment, talking with the whole team, using risk stratification.
Individualizing the plan.
Individualizing, exactly. Using strategies like the liquid diet or POCUS when needed. It's about adapting intelligently, not just defaulting to cancel.
Which leaves us with a lingering thought, doesn't it?
Yeah.
As these drugs get even more potent, maybe longer-acting versions appear, and, even more people start taking them.
Yeah.
How will our understanding evolve further? Will we get a better handle on tachyphylaxis? Will long-term use change the gastric emptying profile significantly? How will that shape our fasting guidelines down the road?
A question for the future. Definitely something to keep an eye on.